sort of had to concentrate for the last two hours or so. So very keen that you ask the experts some questions. So I'd like a volunteer to ask a question. Do we have any volunteers for a question? Right, well, let's maybe change tack. We talked a little bit about sort of endothermal ablation laser versus radiofrequency. Do you think there are going to be changes with respect to those two techniques, or do you think they have now reached their sort of, inverted commas, maximum capacity, that really any further improvement really is not going to be any improvement at all? Case.
Well, I think they're close to what's in it, and there might be some subtle improvements, but as long as it's thermal ablation, we will stick to the fact that we need tumescent anesthesia, etc. And I think the biggest improvement will be that we some way get around that, and then we won't need any anesthesia to occlude the vein forever. And I don't know for sure, but if those both techniques have that in it, I don't think so. I think they are at the end of the line, but you never know.
Hello?
I agree with Case. The only question I have is, have we reached our pinnacle of wavelength? You know, as we go up the water absorption curve, we have more affinity and therefore we need less power and less energy. However, if we look at the other end of the spectrum, the ultraviolet or the near violet, that also carries the same thing. I would love to be able to do away with tumescence, and as we go forward, at least in the U.S., with proprietary foam nearing its success in somewhere around 2013 or 14, it'll probably come to market. We have Claravane at this point, which is tumescentless, and then Saphion, which is now working with glue. You know, I think that's our next frontier in terms of, as you say, tumescentless anesthesia.
Tim?
I think the improvements could be in the ease of use, to be honest. I trained on the RFA of the old system, which was considerably more fiddly than the new system. There's no doubt the closure fast is much better, but now I find that laser is a bit fiddly compared to the RFA, and I think there could be some improvement in how easy it is to use it. I don't have any great ideas how they do that, but I'm sure that's.
I think we will have some development. I agree that tumescence-less methods will be one of the main issues, but then we will have also developments in the fibers, definitely. I'm quite sure, with the goal to go lower in energy, maybe with the same occlusion rates, and then maybe we have a period of combined treatments. Something you can do to have a spasm in the vein and then use less energy and things like that. I think we are just at the beginning of this, but in the rest I agree. Yeah.
Manj?
I think our big revolution has already happened. The transfer away from surgery to endovenous was a big revolution. I think from now on there will be refinements, of course. Catheters will get smaller, they will get easier to use, and potentially we may even get away from tumescence. But I think where the greatest need is in better patient selection and in better tailoring our treatments for the patients that we have. But I think the big revolution has obviously already happened.
Eberhard, would you just like to pass a comment on, because certainly coming back from Australia, what seems to be becoming popular is the use of tumescence with foam to actually get the vein to be small to then put in the foam. Would you? It seems a slightly retrograde step to me.
Yes, sorry.
Sorry.
I think that's a good issue to have the vein smaller if you use foam. But everything you do with tumescence in foam sclerotherapy makes the method more complicated and more sophisticated. And as we want to get away from tumescence anesthesia in endovenous heat procedures, why should we introduce the same in foam sclerotherapy where we do not really need it for, let's say, for pain reasons or whatsoever? The only issue would be if you want to treat very big veins with foam sclerotherapy, but then we have also other methods. If you use tumescence you can also use endovenous heat terminal ablation.
I don't disagree with you, but I'm just this seems to be a trend that's
Yes.
slow.
Early on in my career, I looked at the saphenous compartment and did wick pressures as I did incremental tumescent anesthesia. And I found that it was very difficult to increase that compartment to 2 millimeters, where 35 millimeters, in a fascial compartment is worrisome. So knowing that the compartment is wide open and knowing the absorption of fluid in the subcutaneous tissue, I think it's theoretical.
Case?
Well, I just want to get back to the ideal situation. I heard that patient selection should be the way to go, et cetera, and that we have a new era in which we have endovenous treatments. And you know that I'm still aware of the fact that surgery still might prevail due to the fact that the recurrence rate with the endovenous procedures in the groin is too big. There are so many people who always state, okay, you can redo it if you have an accessory vein after an endovenous ablation. You can treat it again endovenously, but if I look at the data which the patient represents, is that I want to have one treatment, then the crossectomy might still be a way to go. And I'm still waiting for a center to do a randomized trial with or without crossectomy because nobody has ever done so. There are some data out there, but they all lack a type 2 error. They don't show a significant difference, but those are 40 against 40 patients or 30 against 30. So I'm still waiting for the fact for if crossectomy is really dead. If that's dead, then I fully agree with the fact that the endovenous treatment will prevail and will be the way to go. But if the crossectomy shows a significant improvement in the clinical outcome of a patient, then I'm still, I'm curious how the future will look like.
Okay, so could you just define for me what you mean by crossectomy?
Just a high ligation with side branch ligation.
Because I think there would be those who might even argue that you could just ligate the main trunk and leave all the side branches.
No. I'm just meaning that you really ligate all the side branches, have a flush ligation on the common femoral vein. Okay. That's a crossectomy to me, and not the von Rockley type with you have to go to the second or third generation side branches. No, leave it as. I think it relates to the fact that the crossectomy has a negative impact due to the fact that you have neovascularization, but if you do a duplex-guided pinpoint crossectomy without too much of surgical damage creates neovascularization. No surgical damage, no real vascularization. So I think, although Lowell is trying to get into me, I'm not going. I keep on talking, so you don't get a chance.
Lowell, you're on the stand. You can go.
Yeah. Thank you. I think that there is a question about how you define recurrence with endothermal ablation. And last we talked, your definition of recurrence was, matter of fact, a new tributary that was refluxing as opposed to a true recurrence like you see with neovascularization. I agree with you, trauma does cause neovascularization and crossectomy. What also causes it is frustrated venous drainage. And when you have frustrated venous drainage, when you go past the primary division of the tributaries, there's no place to drain. So you get these inconsequential veno-venous anastomoses that dilate. So I think that would lose hands down.
Yeah, but now you're just trying to get scientific on something which we don't know.
Oh, yes, we do know.
We really have to do a randomized trial with and without a crossectomy with significant numbers to prove, and then after these results are known, then we can theorize about why we observe those things. But first, medicine is not...
Right, fine. Let me just stop there. Okay, so you've got a big vein practice. Are you going to do it? The trial?
The trial, just randomize them between stripping and tumescent stripping, only tumescent stripping with crossectomy, and then as a control a venous or a laser ablation.
Are you going to do it?
Yes.
Okay.
But it's difficult in Holland because in Holland 80% is endovenously treated, so surgery is not that very common anymore. But if you go throughout the world, 80% is still performed surgically, and I think that's why we have also as vascular surgeons has to promote an improved surgical technique and not only talk about endovenous treatments.
But presumably, having listened to Eberhard, you could get your German patients to be the ones that are operated on.
But Eberhard is so eager to keep them themselves. I don't see any patients of him.
Isaac, let's have a question from the floor.
I know
Go ahead, the microphone.
Question to Manj and the panel, really. I don't share your enthusiasm that the revolution has happened. As we saw in the data from the NHS, many of our colleagues continue to operate on patients. What ideas have the panel got to persuade the people outside this room that the endovenous revolution is the way forward?
I think the one thing I've learned from this morning is if you want 10 ways to treat varicose veins, then ask 5 venous specialists. I think maybe we should think about an alternative, which is to get away from the nitty-gritty of lasers and radio frequency and wavelengths, and to think more about outcomes. I've got no doubt that if I had varicose veins and I went to case and I had an open operation, I'd have an excellent result. And similarly, if I went to Lowell and had laser, I'm sure I'd have an excellent result as well. And I think that going to somebody who is confident in their technique, have refined their technique, is always have to think about those, and using one hammer to hit every nail is not necessarily the right thing.
Sorry, I didn't make myself clear. I meant we should all be offering, at least to some degree, an endovenous option.
Mm-hmm.
In this country at the moment, many of our colleagues aren't. What ideas have you got to persuade them to do so?
I mean, I think it's a multifactorial approach. I think, obviously, education, enthusiasm, and training. I think that we need to demonstrate the benefits, but still people need to be interested in their own local practice, and it needs to be a relevant thing to do.
But Isaac, I think the comeback is that if we were actually offering our patients what we're meant to do with the NHS, we would actually be telling them about all the treatment options, be they surgery, endothermal, or foam. My suspicion is that people aren't doing that. They're only offering people the techniques that they, inverted commas, have. I think the other thing that is difficult is actually looking at the number of vein cases that people do. That in some areas now there probably isn't the incentive in the NHS for them to actually change. And I think there are some of our colleagues who think it's actually a good training operation and it's something that they can actually train their junior staff on.
In the U.S., when we first started, and I first started in 1999, it was done in the hospital. And in 2005, our government then gave a site differential, forcing us to do it in the office because the reimbursement was higher to do it in the office. So we got the professional fee as well as the facility technical fee. So therefore, that was a no-brainer, and the insurance companies realized that they could save money by putting this in the office. So that net flux drove everything to the office, and then subsequently, it was shown that we could do this safely in the office, and that's the fate of where it went. I think it was economically driven.
Gentleman there.
Owen from the Netherlands. Just a question. I'm just wondering if the panel members are not in search of the Holy Grail, because you were saying that you would go to Case Witness to have your veins treated. But I doubt that Case Witness would give you a 100% guarantee that you would not have residual or recurrences, whatever. When are we going to admit defeat? Are we doing the right thing? Shouldn't we be looking more at genetic causes and investing more time into that to get really down to the roots of the problem? Or are we going to just pretend and treat the symptoms all the time?
Well, I think there's quite a well-known vascular surgeon in the UK called Norman Browse, who very nicely summarised this to say that the management of venous disease was a palliative treatment. And I think we probably would all have to agree to that. I think Eberhard may want to talk a bit about the genetics, because there is some discussion between the Bonn group, the Edinburgh group, and the group in Otago. Would you like to comment on?
Yes, genetics is a very important point, I would say, and we tried for now more than 5 years very hard with our data from our patients to get any evidence for some genetic changes, but it's not such easy. So we were not successful up to now, but there are several groups on the way, and I'm quite sure that nobody knows, maybe in 2 years, maybe in 5 years, we will have more information. The second question, if we know something about that, can we change it? That's another issue. But definitely, you're right. There are genetic things we have to know. That also influences recurrence of varicose veins, for instance, after treatment.
Gentlemen.
I'd like to make a comment on my practice of what I do, and it's mainly an endovenous laser, but I always do phlebectomies. and the results are very good, to be very frank, as against a foam sclerotherapy, which, in India, people do not come for cosmetic results. People come to us with C5, C6 when they have ulcerations, pigmentation, and large varicosities. Because the Indian clothing, especially in women, they wear those saris, it get hidden. They're hardly bothered about what their leg looks like. So we invariably land up getting these huge varicosities. From complications which I see from my other cardiologist and radiologist colleague who do not practice phlebectomy, it's really appalling that foam sclerotherapy used. It causes severe thrombophlebitis, pain, and pigmentation to a level. I do not know the technique used by them may not be correct. But what happens here is that there is no consensus towards the fact that what is the best treatment available and what will give you a much better improved result given the size of the veins which are seen. Smaller veins, I think majority of us can get away with the kind of treatment that we do, which settles down even by just looking at the long saphenous ablation. This is one of the factors. And the other thing which I have noticed in recurrences, especially in the calf, once you've done that, if you do a sonography or a Doppler test and look at the calf muscle, especially the soleal vein posteriorly, you'll find a very big soleal vein which drains this kind of tributaries. And sometimes I have done an endovenous laser on the soleal vein itself, puncturing that, and that takes care of the recurrence. It's just my theory. It's not that I'm right or whatever, but it's just I want to know whether anybody has looked at it in this particular manner, in this too.
Tim, would you like to comment, because you're a man for all seasons?
Yeah, thanks. I don't think I've specifically treated the soleal vein in the description you describe, but I think you're right that the important thing is you've got to have a whole armamentarium for treating these patients, and no two patients are the same. And I don't think, coming back to what was said earlier, I don't think people who can only do one treatment should be treating varix veins. I think you should be able to offer multiple treatments and at the very least discuss it with the patients. And coming back to what Isaac was saying about the fact that a lot of our colleagues only do surgery, and they've always only done surgery and they're stuck with it, and I think that's wrong. I think we need to start putting pressure on people that they've got to offer more treatments.
But would you not have to agree to sort of, in a way, be slightly to defend our colleagues, that if you actually look at the 2-year data, if you look at LAST's 2-year data, and you were a healthcare community physician and you were looking at somebody wanting to change practice, that actually surgery gives you as good results as endothermal ablation, gives you as good results as foam. We're all very much arguing it from a vascular surgeon perspective, but actually if you were the person who was doling out the money, how would you actually persuade somebody to change?
Because it's not all to do with money, it's to do with quality of life and the patient satisfaction and all the rest of it.
But that's where I want to interfere, because if you talk about quality of life, the studies who prove that endovenous treatments have a better quality of life, then they are talking about day 6, between 2 and 6 hours in the afternoon, that the pain score is 3 instead of 2.5, which is highly statistically significant but clinically completely irrelevant. And if you look at the questions asked for patient want to have a treatment in one step and treat all. And if it's a bit more painful, they don't care. It's a bit more bruised, they don't care. They just want, because after 3 or 6 weeks, it's all over. So I really want to offend to the fact that we are in a country where the money allows us to use those modern new techniques. But if you're in a country where you don't, and that's about 80% of the world, surgery is a perfect technique. The only thing we have to do as surgeons, that we have to do it in the proper way. Duplex guided, under tumescent anesthesia, in an outpatient basis. And then it's, as Lars' trial shows, and also the Dutch trial where I refer to from Moy, that those data are exactly the same as any endovenous treatment. And if you then combine it with all the other surgical things like phlebectomies, then surgery is a perfect technique. The only thing is that we like those new tools and we like to improve it. And I think we should certainly go on with it, because we might find a solution to get a really significant improvement. But up till now, surgery in the proper trials comparing with the endovenous treatment is exactly the same. So I certainly don't want to say that you want to persuade all the UK surgeons to try and do endovenous procedures. No. Learn them to do it in the proper way, the surgery, and then it's a perfect technique.
I have to come back on that. We demonstrated that you get back to work much quicker if you do RFA compared to surgery. And therefore, they're costing the economy. If you're going to have surgery, you're costing the economy a lot more by the fact you don't go back to work for 2 weeks. Whereas you go back to work within a few days with RFA.
It depends what you tell the patient.
Is that the patient's expectation? Because when you were randomising, you would have probably had an information leaflet that said, the reason for doing this trial is that we think you will get back to work a bit.
No, we were very clear about that because we sort of preempted that before we did the trial, and we guessed that would influence it.
Well, then you're talking about the UK people, but in Sweden and in Norway, the trial didn't show any benefit related to getting back to work. They are just at the same time. And if you tell the patient that they can go home and work the next day, then there's nothing. It just relates how you communicate your problem. It's the same with cholecystectomies. We did mini cholecystectomies with mini incisions, and those patients also went home the day after the surgery and went back to work. But the laparoscopic people said, well, this is the only way to do it. But it depends on what kind of information we give to the patient. And then they can go to work the day after.
To a certain extent, of course, you are right, because in the worldwide situation...
I would stop there. That's good.
I'm right. But as you know, it's always just coming back after the first sentence.
Yeah, okay.
So, but the worldwide situation is, of course, that we are not treating patients with 6 millimeter veins, but much bigger veins like in India. So it's a big difference also between the patients' collectives and so on. The other point is, I think the best thing the new methods have brought was that the surgeons have started thinking about their own treatment. So that because things like using duplex in the operation theater, things like that, being sure that you're stripping the right vein and not the wrong one, and things like that, improving your, let's say, being less invasive and things like that, that only has started when the new techniques came on the market. And I'm quite sure that also surgery will become better than with the bad recurrence rates we have from the older studies.
Yeah.
So this is, I think, this is a fortune.
Yeah, absolutely. I fully agree.
I think did you want to ask another question?
I want to answer. I really have
Okay.
a burning. I'm sorry. I think that case is always argumentative, and I like that. But I'm just as argumentative. So you're talking about the great saphenous vein, and I agree with you that if you do the proper technique under the proper conditions, you're going to have good results. Let's shift to the small saphenous vein, where all of the studies, in terms of surgical studies, have fought with issues with the small saphenous vein, from people stripping arteries to neuropraxia to misidentification, because again, it was not done with ultrasound guidance. But going further, I think that the small saphenous vein is a completely different animal. It behaves differently even with endothermal ablation, but I still would rather have, if you ask me whether I'd want to be stripped or endothermally ablated, I'd go for endothermal ablation any day of the small saphenous vein, just teleologically.
Yeah, let's have a...
I'd like to give you a small example. When I started doing endovenous laser, I was not very confident. So whatever bilateral cases I had, one side I did surgery, the other side I did endovenous ablation. You will be surprised to know that the side in which we did surgery had much less pain as against the endovenous ablation. And they absolutely correct, because after 48 hours, the patient starts to sort of limp on the side of endovenous laser as against the surgical thing. And the surgical incisions are so small, and that really does not bother them so much, because even your phlebectomy incisions are very tiny. So I do not buy the fact that, just because you've got new technologies to use, that they cannot go back to work. It's a mindset, as he rightly said. If you convince your patient, I've done this surgery on my wife. My wife is a urologist, and she started working the next day. And she did a TURP after that. without any problem. But at the end of the day, it's a question of your mindset. If you are convinced that it's not going to be a problem, it's never a problem.
Well, I agree with your concept of mindset. I think it is quite important, but
I just have to come back. We did a randomized controlled trial. They were randomly allocated groups, and they were both treated the same way, and we showed a difference. And that's the whole thing about a randomized controlled trial. That's why you do it.
Related to your laser treatment, that's more painful. I don't know if you did tumescent, at least fluid around it. Because we've seen sometimes we get patients in who have been treated on a general anesthesia, and they burn them, and then they don't put any fluid around it, and they have a lot of complaints because they have a perivascular inflammation.
Let's just go back to your short saphenous vein. What were you doing? Were you actually just ligating your short saphenous vein, or were you actually stripping it? So, yeah.
No, we only ligate it.
Well, I think if you're only going to ligate it and comparing it to an endothermal ablation, it is a bit of not comparing apples with oranges, isn't it?
I was not referring to the short saphenous. My argument was about the long saphenous stripping and versus endovenous ablation for the long saphenous vein. The short saphenous vein, when you do endovenous, you obviously are doing from the mid-calf upwards, whereas surgically, you never strip that, you just ligate that and remove just a section of that vein. That is what my teaching was. And another factor is that now what I see a difference today is I'm still of the old school of thought where I start puncturing just around the knee and go up. But from what I hear and seen today, that people have now started doing punctures much lower down and started ablating the whole of long saphenous vein at various things. So the concepts are changing, and it will take time for people to digest this kind of thing in their practice. That's what's good.
Okay, I think if we can just maybe move the discussion away from which is the better technique, because I think probably everybody would agree that they, inverted commas, all work. It's a bit whether you go in your Rolls Royce or your Daimler to the airport. They all will eventually get you to the airport. But do you think how do you think we should be treating patients with C2, C3 disease? Some of us are lucky enough to work in a system, or some people may work in a system where money is of no object. Other people are in a restricted budget. Do you think we should be offering people a different treatment regimen if they have C2 compared to C3 disease? I don't want to get into C4, 5, and 6 because I think we'd all agree that they need to be treated. So could we, Manj, if we start with you, would you offer anything different for C2 versus C3?
I think it's a very difficult question. I think there's a lot of C2 patients who will not necessarily progress to C4, 5, and 6 disease. And we have to be realistic. With the current economic climate, it is going to be difficult to justify treating everyone with C2 disease. I think with C3 disease, it depends on the patient's symptoms. There are some people with severely disabling symptoms who cannot go to work. And I think the quality of life gain in that sort of patient will be potentially significant. But I think we need further efforts to try and work out which patients will progress to the chronic venous skin changes, to then further focus which people we should target most.
Eberhard?
It's definitely the case that there are some people in the C2 stage which are on a higher risk for progression. This is, for instance, obese population. And of course, it's a question if we at least should treat these patients. The other point is, of course, the question how to treat the patients in the C2, C3 group. And today in the morning, we had a discussion on doing more phlebectomy, for instance, looking more for varicosities, not for reflux in the great saphenous and small saphenous. This is also an option, of course, also in this group. We don't have very good data up to now, but it's at least a question for discussion.
Tim?
I think they should be treated the same, really, but I accept if money's tight, then you can't treat everyone, and maybe you can't treat C2 level disease. The only thing I would say is, supposing you have a 17-year-old female who's got pretty horrible-looking varicose veins and no particular symptoms from them, apart from the fact she doesn't like them, I actually think that's reasonable to treat that patient, and I wouldn't want to live with them for the rest of my life if I was her.
Okay. Lowell, from where money is no object, the land of the golden apple, where you can do anything you want, anybody will pay for it. What do you think?
No, not anybody will pay for it, the government or insurance companies. This is a really difficult question to answer because it's multifaceted. And for me to simplify this answer would be cruel. So I'm going to go from one spectrum to the other. Asymptomatics, very easy. Stockings. Pain in the United States is all relative. So pain, what degree of pain do you have? And everybody knows in the United States that they have to come in presenting with pain, otherwise they're not going to progress. So I can't ferret that out. Now, some of the ideas that I can ferret out is, does it interfere with activities of daily living? You know, what activities can't you do with your disease process? I'm not even talking about the amount of peak systolic reflux or any of those things, or the degree or what the pattern is, because obviously you're going to tailor your treatment, whether you're doing a phlebectomy alone and seeing whether the reflux stops, or because the vein is so huge you're going to go ahead and do it. But I think it really has to do with the patient's symptomatology for C2, and that's where I'm going.
Okay.
Well, that's an ethical and a medical issue. Well, the Dutch are different. They come from the golden age, and they just trade and they earn money. And the only thing which is an issue is how to collect a lot of money out of your practice. And for instance, at this time, C2 patients are close to being abandoned from being reinsured. So everybody is now looking at C3 will be insured. So I think the incidence of C3 in Holland will increase enormously. And I think so without any different, we will treat C3 patients on the same education as C2. So in my opinion,
what is a C3 Holland?
C3 Holland that's going to be invented because that's where they will earn money. So probably they will have edema on their eyebrows, which represents edema on their legs.
I have difficulty
and that
with
has
C3,
to be treated.
period.
Right.
But that's the Dutch. I will always argue about medical and financial arguments to do a treatment. And to be honest, varicose veins allows a huge amount of economics being involved. And this is the same. I fully agree that C2, we know from the data from Eberhard that it progresses to C3, C4 in a significant number, and the quality of life is getting impaired. That's the medical side. But on the Dutch side, we know that if C2 is not going to be reimbursed anymore, we will search for C3, and we do our outpatient clinic not in the morning anymore. We will do them all in the evening, because they will have C3 in the evening, and we will push, and we'll see that there's edema. And that's where the treatment goes.
I'm coming to your clinic to learn how to do it. That sounds good.
I think one of the problems is that maybe the question of C2, C3, C4 is the wrong question, because that is not a severity classification. And a patient having a severe edema may have a much more severe venous disease than a patient in C4 which has just a little eczema or a little pigmentation. And we have to get to a situation where we have better data on the severity of venous disease and not only on classifications like C2, C3, and things like that.
VCS scores.
So do you think the VCSS is up to it?
No, the VCSS is designed much more for ulcer patients for severe disease. It does not really represent the lower, let's say, classes of
Yeah, I fully agree. I think C2 has to be divided. C2 is a one basket of a huge amount of disease, from tiny varicose vein to the people which may come from India with huge.
Okay. Isaac, and if there are any people in the trade who want to ask some questions, do feel free. Isaac.
Did I hear Eberhard correctly that we should be treating obese patients who are C2? Because if that's the case where I come from, they'll go and eat more, become obese, to gain treatment.
Okay.
Well, I just anecdotal, talking about obese. In Holland, you get treatments for free for obesity if you are a BMI of 40. You get patients in with 35, and they start eating to get above 40 before they get the treatment. And then they be healed, and they go back to 35.
So in Germany, it's the other way around. We
That's
try
the
to get them down, but they get up.
But
so.
it's amazing system.
Alan, I think you bring in a good point about how to stratify C2, and we've all been thinking about it, whether you use the modified VCS score in combination with the SEEP classification, as well as activities of daily living retardation. I don't know the answer, but I think we're going in that direction. And I think it's really important for us to establish that criteria before it's thrown down your throat in Holland in the land of opportunity in the United States, as well as anybody else.
I think we all agree. Speaking medically and ethically speaking, that we have clear evidence that to treat the venous disease is cost effective. So this is one point, that's evidence. So if you have a patient with a venous disease that is interested in being treated, doesn't matter if it's for cosmetic reasons or symptomatology, and you know that it's cost effective, you should fight for a system that allows to treat all these people and not try to turn around if it's C2 or C3, and if it's C2, it's C3 in the afternoon or something like that. So we have to face that if it's cost effective, we have to offer to the patient if he's interested. Even when you choose the things you are doing, you have to be very, to explain him the advantage and disadvantage, and including, let's say, at final, I think that when we decide to do something as doctors, we have three things to consider: the evidence, clinical, the scientific evidence, our personal belief, let's say, if I'm very clear in my mind, and the patient preference. So we have to play with these three things and decide ethically and medically according. So thank you.
But how would let's just go, and a question to you. You have a limited budget. You can only afford to go on holiday once in a year rather than twice in a year, and you have to have your quality of life is equally affected by your varicose veins as it is by your knee, which is giving you some arthritis. But you can only have one of those treated. How would you make that decision? They're affecting your quality of life equally.
Well, probably I will tell the patient it's better that you don't go on holidays and you treat your varicose veins. So it's also a priority of the patient. You have to decide that you have to some things, because after all, the National Health Service is not free, as you used to say. It's free, or let's say, we want it is free when we need, but we have to pay it before. So you have to consider if you have money to pay it before, and here there is priorities, political priorities. If you consider that to treat the patients and disease and health is really a priority, maybe it is. So you have to consider how you are going to arrange the money or to finance the system.
Okay.
I just want to make a comment more that if you look the concerns of the reimbursement system, is that if you look at the American system, that they have an 8-fold increase in numbers of venous treatments. And that's we are now having the discussion with our general insurance government and the insurance companies that they are so afraid that will happen that they will try to get rid of it. So although you have proven that the quality of life will increase, but there will be a situation that it's unaffordable, and that's where the Americans are heading, and that's where at least in Holland they are very, very afraid of. And I don't know how those things can be taken care of, because, well, the success is so big in the States that, yeah, people get, without any other indication, normally they couldn't have had the surgery, they are too old or too fat or whatever, but they can get those endovenous treatments, and that's where it goes sky high.
You know, we've never really restricted care in the U.S., and it's very interesting that venous disease exploded in the U.S. based on minimally invasive procedures and education, and patients are self-referred. The majority of our patients come to us by themselves. They see varicose veins, they come. They know how to play the game, but I think what we're embarking on is there's not an unlimited pot out there, and we as physicians are the best to control that pot because we know what the severity of illness is. And I think you were alluding, maybe I'm thinking with you, to put venous disease on a scale of venous severity, or excuse me, a severity period, a comparison to somebody that's, needs a total knee. I mean, it is miles apart to cancer, and we can extrapolate from here on in, but maybe there has to be that type of thought process.
Well, just to comment on that, in the UK, there has been, using the PROMs that we've sort of touched on, people looking at the outcomes, and I accept it wasn't to decide who was to be intervened on, but having looked at total knees, total hips, hernias, and varicose veins. There were 24,000 varicose vein procedures, and my recollection is correct. The hips and knees were somewhere around about 50 to 60,000 cases, and the hernias were around about 30,000 cases. And what was interesting is the hips and knees had the greatest gain, then it was the veins, and it was actually the hernias that actually had the lowest gains from the PROM data when they looked at it. So I think there are some comparative data out there, but obviously different tools we use for doing the measurements, but most of that was based on the EQ50. Sorry.
I was just probably saying, if you have a hernia, you would probably be sent on vacation. You've got to look good, get veins treatment. You know, I mean, you don't want your arthritic joints. You don't want to go water skiing. Just lie down in the sun. I'm just wondering, if you have an eightfold of American costs, are the American people more happy? You know, as long as it's free, as long as they're getting it reimbursed. But are the American people more happy? Should we Europeans be jealous and try and sort of imitate that model?
I think the doctors are happier.
Yeah, absolutely. So the Dutch will be too.
I can just pass you a comment on it, because we've done a very preliminary study, and we're just about to present it at the UK Venous Forum, is that we have actually found that compared to UK norms, and you may accept the UK norms are depressed in any case, but people with venous disease are depressed compared to the rest of the population. So whether you'll find that of any interest at all, but the answer is that they're not as happy.
Before or after that treatment?
Oh, this is just before. Everybody looks slightly stunned. I know we talked about it earlier on, and there are the various trials, and we've heard from Case, so I'm not going to ask Case this question. Case has told us what he thinks is the next trial, the important trial. So I'd like to go through the other four of you and tell me what you think is the trial that should be done in the next 5 years. Lowell.
I'm going to pass for now. I have to think about that one.
Okay.
I mean, from what Jonathan Earnshaw was saying this morning, we have no idea what compression to put on our patients after we've done all these different treatments, and we spend quite a lot of money putting stockings on patients and bandages.
We are already doing that.
Are you?
I presented that data this morning.
Okay. So you've got to have another go, Tim. Eberhard?
We need a long-term outcome study on the effects of treatment. What we don't have now. We have just studies, comparing special methods. But data on, let's say, progression of the disease influenced by treatment. It may be compression treatment or may be interventions or whatsoever. We don't have any of these data. We don't know for this question what is the amount, or what can we influence the development of C4 disease, C5 or C6 disease? What would be the outcome with compression therapy alone, or with surgery, let's say, or intravenous procedures in a C2 patient after 5 years, for instance, or after 10 years?
So do you think that we should be looking at, not repeating, but with the treatment options, be looking at repeating a Bonn, Edinburgh study, but on a much bigger, either pan-European or pan-world? Because I perceive that there are differences between populations.
Yes, we will have some data on the populations with the vein consult study, but we don't need so much more epidemiologic data. But what we need now is really an interventional arm, a randomized study of those patients of the general population with varicose veins, let's say, who one part is treated and the other is not treated, and what happens with the two populations after a long run.
Do you think you'd be able to randomize patients?
This is an issue, of course. It's very difficult, and it would be quite an expensive study, of course, with a big amount of loss to follow-up patients. But at least we have no data on that. I think that would be an important information.
Manj?
There's lots of trials, but I think another leg ulcer trial is probably needed. I think that aggressive early treatment of superficial reflux, in addition to compression, because if we can get these ulcers healed even a few weeks sooner, the impact on quality of life and on cost could be enormous. And I think we're talking about the sort of C2 disease, but let's manage the leg ulcers better.
Okay. Lowell, I'm going to let you. You've had time to cogitate, think,
And so everybody's mentioned superficial venous disease. I'm going to go into deep venous disease for a moment. I think where we're headed in terms of pharmacomechanical therapy for iliac obstruction, I don't think the trial out there is really fair. They're comparing it to old methods. I think pharmacomechanical should be going against long-term Lovenox to see if there really is a difference, because we know we know that Lovenox does have ability to help in terms of recanalization.
Okay.
And those patients do better on Lovenox than they do on Coumadin in terms of recanalization.
would you put surgery into that? Because that's where there
Yes,
is. You would
versus
put-
pharmacomechanical.
Okay. Okay.
Just a general remark related to trials. I'm always astonished by the fact that we are so proud on the fact that venous disease is so widely there in our community with 30% incidence, and then so we have 10,000 in each country, and we still are talking about trials 10 against 10, 20 against 20. So I really should stick to better randomized trial with clinically important outcome, not the pain score on day 5 between 5 and 6 o'clock in the afternoon. No, important outcomes which we can decide on what to do with it, and no type 2 errors. The venous outcome trials are nearly all type 2. They're not significant, yeah, because they are just 2 tiny groups. And I think that's the most important. If we could improve that, then we can answer a lot of questions.
I think it's like all these things, Kees. I think everybody would agree with you. It's all a matter of actually persuading people that they will want to fund bigger trials and get people to recruit to them and agree to a standard protocol, because as we all know, people have various variations. Well, I'm actually going to sort of call this to an end, and I'd very much like to thank the panel, because we have got another session starting at 1:30, and some of the panel members are partaking in the next section. But thank you all very much for coming.